Hello, my dear students. I hope you are doing well. I am Associate Professor of Department of Human Anatomy and Medical Terminology of Azerbaijan Medical University, Anar Abdullayev. And today we will talk about the functional anatomy of urinary organs, their development in ontogenesis, their variations and abnormalities. I prepared this special plan for my explanation. First of all, I'll talk about the urinary organs, their morphofunctional features. Then I'll explain you the development of urinary organs and their variations and abnormalities. Look at this picture, please. The urinary organs form the urinary system. This system includes the two kidneys, paired organ, right and left kidneys, a right and left ureters, unpaired urinary bladder, and unpaired urethra. Urinary system and genital system, these two systems have some morphofunctional, also embryological, the developmental common features. And it also shows in their extrauterine life, in extrauterine formation and the functioning of this organ. For example, male urethra has dual function. It takes place in removing out of the urine also the sperm, and the female urethra opens into the vaginal vestibule. The kidneys, of course, the main function of the kidneys is the removing out from the body the the excretion of the excess water and some waste materials, which are very toxic, and the kidneys act as a filter of the human body. And these actions also very essential for the control of concentration of various substances in the body, maintaining electrolyte and the water balance approximately constant in the tissue fluids. It means the balance of the liquid part of our body is very important, and the kidneys also have endocrine functions, producing and releasing erythropoietin, which affects the red blood cell formation. Renin, the kidney also produces the renin, which influence the blood pressure. 1,25 dihydroxycholecalciferol, it is the metabolically active form of vitamin D, and is involved in the control of calcium absorption and the mineral metabolism, and also various other soluble factors with metabolic actions. Two kidneys, yes, you know from your practical classes that the kidneys are bean-shaped organs. They are located on the posterior wall of the abdominal cavity, retroperitoneally. It means the behind than the peritoneum. And each kidney has two surfaces: anterior, slightly convex, posterior, slightly flattened surfaces, superior and inferior poles or extremity, extremitas superior, extremitas inferior, lateral border, margo lateralis, which is convex, and the medial border, margo medialis. This border has the concavity at its middle part, form the hilum renalis for blood vessels and the ureter. Of course, the blood vessels, the renal artery, which enters into the kidney, and the renal vein, ureter, they leave the kidney along the hilum, and the location of these organs on the door, on the hilum of the kidney, on the hilum of renalis. The vein is located anteriorly, artery slightly posteriorly, and behind these two structures, the ureter. And as you know, by the aging, these structures become elongated, and the kidneys by the age they go downward, and the angulus between the two kidneys, if we provide the special angulus, it means the inferior poles of both kidneys becomes the closer to each other, but the upper pole, upper right and upper left pole, the distance between them increases. This angulus is open to upward renal angulus, and the long axis of each kidney is directed inferolaterally and the transverse axis posterior-medially, which means that the anterior and posterior aspects usually described are, in fact, are the anterolateral and the posterior-medial. An appreciation of this orientation is important in percutaneous and endourological renal surgery. You are looking at this picture. Our left kidney locates close to the abdominal aorta, and the right kidney very close to the inferior vena cava. And you are looking at the right renal artery, this one, left renal artery, renal veins, the left renal vein and the right renal vein, also right ureter and the left ureter. Like the kidneys, the ureters also are retroperitoneal organs. And the urinary organs also are shown here, the paired kidneys, paired ureters, urinary bladder, and the ureter. On the superior pole of each kidney, we can observe the corresponding suprarenal or adrenal glands. They are very important endocrine organs. And what about topography of the right and left kidneys? First of all, I have to note the topography of these two organs is not similar. Right and left kidneys are not symmetric. Right kidney locates slightly lower than the left one because the large size of the liver. And the upper pole of the right kidney is located at the level of the 12th thoracic vertebrae, and the lower pole of this kidney is located at the level of the 3rd lumbar vertebra. As I noted, the left kidney is located upper than the right kidney. The upper pole of left kidney is located at the level of the disc between the 11th and 12th thoracic vertebrae, and the lower pole of the left kidney is located at the level of the disc, intervertebral disc, between the L2 and L3. L2 is the 2nd lumbar and the L3 3rd lumbar vertebrae. This is the posterior view. You are looking and the relation of the right and left kidneys to the ribs. Mainly, our right kidney is in contact with the 12th rib, but the left kidney is in contact with the 12th and also with the 11th ribs. And by the age, of course, the topography of the kidneys is changed. And I told about the transformation of the angulus and transformation of the renal structures. I mean the artery, vein, and ureter. They are descending process. It's very important. And you have to know that despite of the very close contact of the right kidney with the liver, in early childhood and especially in newborn, the contact between the right kidney and the contacting surface between the right kidney and the liver is relatively small, because the right lung doesn't develop well and the liver is located superiorly. It means the right kidney slightly inferiorly, and the contacting surface between them is small. Also, the right suprarenal gland and also left suprarenal gland, these glands, they occupy the relatively larger surface on the superior pole, also on the anterior surface. They occupy approximately 1/3 of the surface of kidneys. And if we'll continue, we have to know the relation to organs, the syncope. Syncope, you know, the topography. Of course, it's topography, but it means the relation of the kidneys to the organs. In this picture, you are looking at the right kidney and the left kidney, and the surfaces, contact surfaces with the neighbor organs are identified here. For example, what about the posterior surface of both kidneys? Posteriorly, they are in close contact with muscles. I mean the musculus quadratus lumborum, musculus transversus abdominis, and also musculus psoas major. These three muscles are very important in fixation of the kidneys. Anteriorly, right kidney is in contact with the liver. 2/3 of anterior surface of right kidney is in contact with the liver. I mean the adulthood period. And the one lower third of the right kidney is in contact with the hepatic or the right flexure of the colon. You are looking at the picture. And the medial border of the right kidney is in contact with the descending part of duodenum. Very close contact. And during the surgical operations, non-experienced doctor, non-experienced surgeon unfortunately can damage the right kidney during the operation on the duodenum. And in the early childhood and in newborn, the contacting surface with the intestines of the right kidney is larger. And the right kidney in newborn can contact with the appendix vermiformis and also cecum. You know, these organs descend during the intrauterine life, descend from the right hypochondriac region to downward. Left kidney, the anterior surface of the left kidney, we can divide into 3/3. Superior third is in contact with the stomach, middle third with the pancreas, the inferior third with the, of course, jejunum, loops of the jejunum. Laterally, lateral border of left kidney is in contact with the spleen and with the left flexure of the splenic flexure of the colon. Next moment, which is very important, it's the covering of the kidneys. What is the covering? It means the structures to cover the kidney. Kidney has a mass between the one kidney between the 120 grams till the 200 grams. The consistency of the kidney is not so soft like the liver, but it is the gland, and mainly it's excretory gland, excretion, kind of secretion. But during the excretion, the excretory organ produces the materials which must remove from the body. Urine consists of the many toxic materials and also part of the water which is doesn't useful for organism. And externally, both kidneys are covered by the fibrous capsule. Fibrous capsule consists of the dense fibrous tissue. And on this capsule, we can find the renal fascia, fascia renalis. Fascia renalis separates the fat into two parts, perirenal and the pararenal. Perirenal fat locates between the capsula fibrosa and the renal fascia, between them. But pararenal, para means the around, it locates on the renal fascia, and mainly the fat tissue good develops on the posterior wall of the kidney. If the person lost the part of this fat, for example, after the long diseases, very hard diseases, the person lost the mass of the body, also lost the part of this fat. Kidneys, both, maybe right, maybe left, maybe both, they descend. Nephroptosis is happened. Nephroptosis, going to downward. And the renal fascia form the special connective tissue trabecula or septa. They pierce the fat between the renal fascia and the capsula fibrosa, and they attach to the capsula fibrosa. Renal fascia divides into two layers, anterior and the posterior layers. On the lateral border of the kidney, it means the lateral borders are totally within the special sac which is formed by the fascia renalis. And these two layers go to upward, and here separates the superior pole of the kidneys from suprarenal gland, from corresponding suprarenal gland. Going medialward, the anterior renal fascia also covers the vena cava inferior and the aorta, and posteriorly it attached, the posterior renal fascia is attached to the vertebral column. It's important. But inferiorly, these two layers go parallel to each other into the renal, into the pelvic cavity, but they don't fuse. They don't fuse. These structures are very important. I mean, the capsula fibrosa, renal fascia, also renal fat, they are very important in fixation of the kidney. And we told about the kidneys, they are covering, and you are looking again on the projection of the both kidneys to posterior abdominal wall. The internal structure of the kidneys, very important moment, because in the cross section of the kidneys we can observe that the mass of the kidneys is not homogeneous. The substance of the kidney is divided into two parts. External, which is dark, cortex renalis, and internal, which is light, slightly light, renal medulla. Renal cortex consists of the renal corpuscles, renal bodies, little bodies, small bodies. They consist of the glomerulus, renal glomerulus structure, and the capsule, the capsula glomeruli or Bowman's capsule. And these structures, I mean the renal corpuscles, are located only in the cortex renalis. But why the renal cortex is the dark? Because the presenting here the convoluted tubules, proximal and distal convoluted tubules, and in cross section they give to kidneys the dark color. And also renal medulla is formed by the renal pyramids. These pyramids are 15 to 25 in number, and each pyramid has been considered like the renal lobe, and because the space between them, between the renal pyramids, is filled by the interlobar arteries and interlobar veins. And each pyramid has the base which is directed to cortex, and mainly pyramid is formed by the straight tubules. It explains the light color of the renal medulla, because all tubules are parallel to each other, and during the cross section we'll get the lighter color. But when these tubules are convoluted, form the many convolutions in cross section, the color is dark. And going to upward to external side to cortex, they form the new layer for the cortex, pars radiata. It means the cortex has two parts, pars convoluta, convoluted part, and the pars radiata, radiated part. And the apexes of the renal pyramids are directed to the renal pelvis. First of all, what does it mean, renal pelvis? Please look at this. The both pictures are useful in this point of view. I explained you the renal hilum renalis, which extends into the renal sinus renalis, yes, and the renal sinus is occupied by renal pelvis and also some amount of the fat tissue. And the apexes together, they form by 2 or 3 apexes together form the renal papilla renalis. Papilla renalis very good pierced by the papillary ducts, ductuli papillaris, and they are opened, I mean the ductuli papillaris, into the minor calyces. Minor calyx is single, minor calyces is plural. The papilla, ductuli papillaris, are opened into the minor calyx. 2 or 3 renal apexes, papillary apexes, are opened into the one minor calyx. 2 or 3 minor calyxes form the one major calyx, and 2, 3, maybe 4, but mainly 2 or 3 major calyxes form the renal pelvis. Okay, I can explain it from the opposite side. The renal pelvis is divided into the 2 or 3 major calyxes. Each major calyx consists of 2 or 3 minor calyxes, and the minor calyxes here are into the each minor calyx is opened 2 or 3 apexes of the renal pyramids. And from this point of view, we will continue our conversation. We have to explain the vascularization of the kidneys, because it's very important, because the kidneys are filters of the human body and they produce the urine. And the producing of the urine, it means commonly, approximately, it's the process of producing of urine from the blood. It means these organs at first they need more blood. And it explains why the both kidneys are located near the main blood vessels of the human body. It's the first. But the more blood, it's not the totally, we can't say that the problem is solved totally. No. Also, kidneys need the great pressure of this blood. And each renal artery, when it enters into the kidney, it divides into the segmentary arteries. Segmentary arteries, there are 5 segmentary arteries in each kidney, and it explains that why each kidney is divided into the 5 segments. The segmentum superius, segmentum anterius superius, segmentum anterius inferius, and the segmentum inferius. Also, 5th segment is called the segmentum posterius. And again, if we are looking at the course of these arteries, then each segmentary artery divides into the interlobar arteries. And I have explained that interlobar arteries, the lobes of the kidney is the pyramid, and interlobar artery is located within the space between the two pyramids. And here, interlobar artery gives off the arcuate artery. Each arcuate artery branches to the renal medulla. They give the arteria recta, but to the cortex, arteria interlobular artery, and interlobular artery gives off the afferent means the afferent arteriole, or simply saying vas afferens. This vas afferens enters into the renal capsule or the Bowman capsule, form the capillary network, the glomerulus, and then leaves this glomerulus under the name the efferent arteriole or vas efferens. Vas afferens enters, form the glomerulus and leaves it. Important moment. There is the difference in diameter between the vas afferens and the vas efferens. It means that in the glomerulus we can observe the stagnation of the blood, and each capsule consists of the three-layered basement membrane, endotheliosites of the capillaries, and the podocytes. These podocytes, they have the many extensions, and they go along this capillary network, and three-layered basement membrane, capillary endotheliosites, and the podocytes together form the filter, renal filter, and between these endotheliosites there is the fenestra or the windows, which each window has the size 0.1 micron, and with this, about the stagnation, due to stagnation, the water and some ions, also other substances, pass from the capillary network into the capillary cavity, into the capsular cavity. And by the stagnation, the hemodynamic pressure transforms to the hemostatic pressure. And I told you about the pressure and is important of the arterial pressure for formation of the blood. If this pressure descends till the 60 millimeter, it means the hyporia or the oliguria is happened, and if it descends till the 40 millimeters, it means the yes, anuria, the formation producing of the urine, is stopped. And this is the first process of the producing of the urine, filtration, or the strictly saying the ultrafiltration. And the primary urine, which is we'll get at the end of this process, has 99% of the water, and the many solving materials, many important ions, several carbohydrates, and the other substances, except the macromolecules of the proteins. Yes, if due to diseases, the structure of the capsule and this endothelioside is damaged, we can observe in urine of the person, of the ill person, there's some amount of proteins. It explains that the capsular apparatus of the reins, of the kidneys, is damaged. And primary urine, I have not has many useful and important for organism substances. It means after ultrafiltration, the second process of producing of urine begins. It's the reabsorption. And in the proximal convoluted tubules, in Henle's loop, and distal convoluted tubule, this process will happen. Again, you have to look at this picture. The proximal convoluted tubule, the beginning part of this tubule, is enlarged. Then it passes to the loop of Henle. Loop of Henle has the descending line. Then it forms the genu, and the ascents. The loop of Henle consists of the straight tubules, and then it goes to upward and pass to the distal convoluted tubule. The final part, the ending part of distal convoluted tubule, is known as the tubulus connectivus, and it is opened into the collecting tubule. Till the collecting tubule, all these structures are known as the nephron, which is the morphofunctional unit of the kidneys. There are 1 to 2 million nephrons in each kidney. I mean, the glomerulus and the capsula glomeruli together form the corpuscle of the kidneys. Proximal convoluted tubule, PCT, loop of Henle, distal convoluted tubule, DCT, with connecting, not collecting, with the connecting tubules form the nephron. Collecting tubules form the mere collecting tubules, and the mere collecting tubule form the papillary duct. Here's the special way. Begins for the intrarenal way of removing kidney. It begins by the collecting tubules, then passes to the papillary duct. Minor calyces, I have explained the major calyces and the renal pelvis. It's the intrarenal part of this way. Extrarenal, of course, consists of the ureters, urinary bladders, and the male or female urethra. In this picture, you are again looking at the structure of the renal corpuscle, and our vas afferens here is here, and the vas efferens also is here, renal capsule. The structures, the blood vessels of the kidney, and you are looking again at the relation of the kidneys to the blood vessels, to main blood vessels of the human body. Development of urinary system is very important moment for understanding what does it mean development, embryological development. Kidney has three stage of generation: pronephros, mesonephros, and metanephros. Pronephros develops at the 3rd week of embryonic life from the little nephratomes, which are located at the lower cervical and the superior thoracic segments of the human body. Together, these pronephric tubules, they are 3 to 10 tubules. They are one end of each tubule is opened into the body cavity, and the glomerulus in pronephros is located outside from these tubules. But the other end together form the pronephric duct. Very soon the pronephros, I mean these convoluted tubules 3 to 10, are reduced, but pronephric duct has been retained. It's important moment. Pronephric duct transforms to the mesonephric duct. Mesonephros or Wolffian body consists of the more segments than the pronephros. It has the segments of the cervical, thoracic, and the lumbar region, and of course the mesonephric duct becomes the longer, and the longer goes downward, and it locates near the primary germ of the sex organs, and laterally is located paramesonephric duct, or the very important Mullerian duct. But about the Mullerian duct we will talk during our next lecture. And the mesonephros and mesonephric duct, don't confuse please. Mesonephros, Wolffian body, and the mesonephric duct, they are very important in development of the main sex organs. And the mesonephric duct, mesonephros, is formed at the 15th, 21st day of intrauterine life, and it goes downward. And during this process, look at this picture. From distal end originates the tubercle, ureteric tubercle. This tubercle ascends to the lumbar region, and then it separates from the mesonephric duct. You can say from the distal end of mesonephric duct develops the ureteric tubercle. It goes to upward to the future lumbar region, and it becomes the enlarged, like umbrella. Like umbrella, form the ureter, renal pelvis, major calyces, minor calyces, and special metonephrogenic tissue is here. Metonephrogenic tissue is the source of development of the final kidney, metanephros. And from the metanephric tissue is developed elements of the nephron: glomerulus, capsula glomeruli, proximal convoluted tubule, distal convoluted tubule, and Henle's loop. Two sources for development of the final kidney. You can say the distal end of the mesonephric duct, or you can also say from the cranial end of developing ureter is the source for development of elements of the renal pelvis, major calyces, minor calyces, papillary ducts, and etc. In this picture you are looking again pronephros, metanephros elements and I have noted the distal end of the mesonephric duct is open into the cloaca, and this cavity then is divided into two parts. Anterior part, the urogenital sinus, and from these elements, from the urogenital sinus, develop at the 7th week of the embryo the urinary bladder, and also female urethra, and only part of the male urethra, because the male urethra has the more complex structure, which I'll explain during our next lecture. But you have to know only prostatic part of the male urethra develop from this urogenital diaphragm, urogenital sinus. Okay, look, you are looking at it. Urinary bladder, as I told you, it develops at the 7th week of the embryo from the part of the cloaca, anterior part, also which is known as the allantois. Allantois. From the body of allantois develop the body of urinary bladder. The deep part, here you are looking at the deep fundus of the urinary bladder. And okay, failure of the kidney to ascend into the renal fossa in utero results in renal ectopia. Ectopia when the organ it doesn't locate at the certain place, which is this place characterizes the normal placement of the organ. For example, kidneys are located in the upper lumbar region, but they are located in the lower lumbar region. It means the lumbar ectopy. Or they are located in the pelvis. This is the pelvic ectopy of the kidneys. An ectopic kidney is found in the pelvis in one in 2,500 live births, according to Gray. Kidneys so placed often have associated malrotation anomalies and may have marked fetal lobulation. You have to know the surface of the kidneys is smooth, but sometimes we can observe they are lobulated. Why is lobulated? Because in newborn, yes, the surface of the kidneys is lobulated because the renal cortex it doesn't develop at the age of 1, at the age of 7, at the age of 14. The renal cortex develops better, and the surface of the kidneys become smooth. Kidneys so placed often have associated malrotation anomalies and may have marked photolobulation. I noted. Pelvic kidneys frequently become hydronephric as a result of an anteriorly placed ureter and anomalous arterial supply. An associated ureteropelvic junction obstruction is often also present. You are looking in this picture when the two kidneys form the elongated structure. You are looking at it. Here is the S-shaped kidney. They form the S-shaped structure. Very rarely, and despite the normal location of ureteric orifice within the bladder, the two kidneys may be on the same side, crossed renal ectopy, and are usually fused, crossed fused ectopia. A solitary crossed renal ectopia may be associated with the skeletal and the other genitourinary anomalies. A number of different anatomical patterns can result, all of which are extremely rare. This is the very interesting abnormality of the kidney, horseshoe kidney. The both kidney connect by their inferior poles and form the horseshoe-like structure. Horseshoe kidneys are found in the 1 in 400 individuals. A transverse bridge of the renal tissue, the isthmus here, often containing the functioning renal substance, connects two renal masses. The isthmus lies between the inferior poles, most commonly anterior to great vessels. It is often inferior to the inferior mesenteric artery, important clinical moment, because this vessel obstructs the normal ascent of the kidney during embryological development. The ureters curve anterior to the isthmus and often have a high insertion into the renal pelvis. It's again the development of the urogenital sinus, and you are looking at the mesonephric duct, and here's the ureteric tubercle ascends to the lumbar regio. The next stage, the branches form the elements of the renal pelvis. Maybe renal pelvis totally, or the 2/3 of the renal pelvis is located outside from the renal mass. This is the extrarenal type of renal pelvis. Or the renal pelvis totally, or 2/3 as minimum of the renal pelvis is located inside of the kidney. It's the intrarenal pattern of the renal pelvis. Again, you are looking at the first stage of the embryonic development, the alimentary tract, I mean the primary intestine, of course, the mesonephric duct, and the mesonephros is here. They are also paramesonephric duct. It develops 1 week later than the mesonephric duct. They all are open into the cloaca. Then the cloaca, by the septum, transverse septum, is divided into two parts. Posterior part belongs to rectum, anterior part to developing urinary and genital organs, and in this stage you are looking at the Mullerian ducts. Mullerian ducts also is very important because its location around the mesonephric duct is also known as the paramesonephral duct. Paramesonephral duct, the important source for development of female genital organs. Mesonephric duct and mesonephric for developing of the male genital organ. Yes, at the first stage of development, the embryo has the both source of development of sex organs, male and the female. After the definition of the sex, when the body embryo develops in direction of the male, it means the paramesonephric duct will reduce. Or if the embryo develops in direction female sex organs will develop, the mesonephric duct is reduced. But from the mesonephros, in female develops some rudimentary organs, and also in men from the paramesonephric duct also are developed some the rudimentary atrophic organs. In the clinical practice, they can cause of the many problems. Again, you are looking at the same things, and this is the abnormalities again of the kidneys. The non-developed the kidney at the one side, and the hypoplasia of the kidney on the one side. Hypoplasia, the weak development of the kidney. Two kidneys at one side and the one kidney at another side. You know, the ureteric tubercle, when it is developed from the mesonephric duct, it maybe can duplicate it. It form the two ureteric, but like in this picture, it explains the development of this case. And during the development, these ureters, future ureters, they can cross each other. They can locate along parallel to each other. They can cross inferiorly and can cross superiorly, or they can fuse, as in this picture. Is that also very interesting clinical case? The absence of the kidney on the one side, on the right side actually. Supernumerary kidney, as I explained to you, two sources for development of the kidney. And again, you are looking at the horseshoe kidney, or the leaving of the kidney two ureters, and the two ureters they can fuse. Very interesting organ. The ureters, very important organ. In your practical classes, it's explained that the muscular membrane of the ureters is two-layered at the upper part and the three-layered at the lower part. And topographically, the ureters are divided into the abdominal part, pelvic part, and very important, very short, yes, but very important intramural part, which locates in the mass of the urinary bladder. Of course, it forms many problems if it doesn't work, but it's very useful during the contraction of the urinary bladder. As a part of its wall, the intramural part also is contracted and works like the mechanical sphincter, and the urine can't return into the renal pelvis. Of course, when this mechanism it doesn't work, the urine returns to the pelvis and form the many problems from the renal pelvis and for the apparatus, the glomerular apparatus of the kidneys. Here is the lobulated kidneys, and you are looking at the two ureters which each one begins from the renal hilum, and the dystopy or ectopy in the pelvic cavity in this picture of the kidney. One kidney has the ectopic placement. And another problems, for example, I have explained your development of the urinary bladder. I have noted that the body of the urinary bladder developed from the allantois, and upper part of this allantois goes superiorly from the primary ureter, the urachus, but it's very soon is reduced. But if it's open, for example, in the newborn from the umbilical ring, we can get some urine. It means the urachus it doesn't obliterate it. All these structures, all these cases are very important in your future practical work, in your future work as a surgeon and a urologist. I have finished, my dear friends. If you have any questions, you can contact with me. Thanks for your attention.